Hello. I'm Donna Murphy, the Vice Chancellor for University Relations, and on behalf of George Blumenthal, our Chancellor, and the entire university community, I welcome you to the 11th Sidhartha Maitra Lecture. This lecture, yes. This lecture was created by the love, vision, and generosity of Anu Luther Maitra, with the support of her family and friends, to honor the life of her late husband, Sid. Though I never met Sid, I and so many people at the campus feel like we know him through this lecture series, which brings such renowned speakers as Abraham Verghese and Nobel laureate Amartya Sen to inform, inspire, and challenge us. The lecture celebrates independent thinking, humanism, science, innovation, art, and philosophy. It is stewarded by the UC Santa Cruz Foundation, and we use it as a highlight of our annual Founders celebrations. But let me introduce the catalyst behind this lecture series, a woman of remarkable intellect, commitment, and passion. She said just to tell her I love her, and I do. She's a great gal. Anu Luther Maitra is a teacher and a role model, a CEO and a volunteer. Her words always are poetic and insightful. She remains an active member of our UCSC Foundation, and she was president for 2 years. She is a friend and a vocal advocate of all that is distinctive about this remarkable university. Please welcome Anu.
Thank you, Donna, and good evening to everybody. This series, named in memory of my husband, Sidhartha Maitra, was endowed by our friends, Kiran and Arjun Malhotra. It is supported by the Office of the Vice Chancellor of University Relations, as well as the Office of the Chancellor. It is religiously attended by my family and friends, and today, I'm especially happy to welcome Sid's sister and her husband visiting here from Kolkata. Welcome, Didi. Thank you all for coming on a weekday evening to hear Dr. Abraham Verghese, professor for the theory and practice of medicine at Stanford University Medical School and Senior Associate Chair of the Department of Internal Medicine. His is the latest in a sparkling array of what have come to be known on campus as the Maitra Lectures, essays really on the human condition and ways in which we can keep alive our humanity, integrity, and empathy. These words are borrowed from a media interview in which Dr. Verghese describes his twin goals for the young interns that he trains: that they understand the diagnostic value of a detailed physical exam, and as importantly, offer comfort and solace to patients and their families. In the past several weeks, as I prepared to introduce and present Dr. Verghese to you, I decided to accompany him on his rounds, not at Stanford, but through his books, 2 memoirs and a novel, his prolific writings for the New Yorker, New York Times, Granta, Forbes, Wall Street Journal, Daily Beast, Texas Monthly Atlantic. But I had a surreptitious agenda. I was going to learn the art of science, learn the art and science of diagnostics from Dr. Verghese, but he was to be my subject. I start my shadowing of him with a tennis partner, set in El Paso, Texas, where he was professor of medicine and chief of the Division of Infectious Diseases at Texas Tech Health Services Center. Here, I watch him meet a young medical intern, a former tennis pro. They trade mentor-mentee roles on tennis courts and in hospital wards, and develop a close friendship at a time when both are struggling to reestablish order and calm in their personal lives. I listen to Dr. Verghese as he speaks movingly about David's struggles with drug and sex addiction, but he also allows me the privilege of peeking at his own vulnerabilities and idiosyncrasies, his failing marriage, his infinite curiosity about the lives of others. His diagnostic skills floor me. I follow him as he goes about his business, sorting out the real-time, real-world problems of living people, visiting their homes to understand their circumstances and diagnose their illness, in Holmesian fashion, missing no clues and making the correct inference from the clues. I take detailed notes as he explains to an intern that the correct application of the principle of Occam's razor requires that the symptoms that are sought to be explained by an underlying model be carefully verified to be true, and related. This book is my introduction to Abraham. I feel I now know him well, so I can address him thus. But through it, I cannot escape déjà vu, a nagging feeling that this is someone I know very well. And before the end of the book, I solved that puzzle. He is the model for my dream master diagnostician from a TV series I'm hooked onto, the brilliant Dr. Gregory House, Chief of Diagnostic Medicine at Princeton Plainsboro Teaching Hospital. I get similarly obsessed with Abraham's life and work. I wish to know him better, and I want more of his brilliantly cut, perfectly syntaxed sentences. I move back in time to an earlier novel, My Own Country, about the emergence of AIDS in the US and its impact on young gay victims, their families, and their communities. Thus, this reader, with no respect for Abraham's chronology, tails him into Johnson City, a rural Tennessee town, where he, with matching disregard for straight-line geography, has arrived along a zigzag path from Ethiopia, where he was born, but whose political turmoil he had to flee, to New York, where he continued his interrupted medical studies as a hospital orderly, to India to attend medical school, and finally back to the US, though now as an intern. Again, he is brave enough to bare himself and talk of his own struggles over the issue of his diasporic identity, his search for a place called home, not just a place to go to, but where he is wanted. I read story after story of alienation, isolation, and loss as he describes his interactions with his AIDS patients, and I sense his unstoppable intellectual curiosity, understanding, and kindness towards them. This time, I think, Purple Rose of Cairo, and I imagine his patients to be Cecilias who see their dream man, a doctor, walk out of the movie screen and into their bleak lives, bringing comfort and solace. The last book on my list was Cutting for Stone, AV's latest book. I'm getting rather familiar with him now, even have a nickname for him. This one is a novel, and it's not just on my list, the New York Times bestseller list, a whopping 87 weeks, still going strong. President Obama's summer reading list of 5 books, the reading list of every book club in the country. I believe that AV has now caught sight of me lurking in the shadows because, as if to cater to my addiction to fantasy, he introduces me to fictional doctors, the protagonist, Marion Stone, his father, the surgeon, Thomas Stone, his adoptive parents, Kalpana Hemlatha and Abhi Ghosh, But now I experience a kind of reverse fantasy in which I remember my childhood doctor, Dr. Suman Shah, a renowned physician who sat with me through my 4th grade exams, the two of us isolated from my classmates because I was sick but loath to lose an academic year. I think of my children's pediatrician, Dr. Robert Burnett, who reached out to wipe my tears and whispered in my ear, "Anu, we only cry about things we cannot fix," inspiring the confidence that he would fix it. He also saved my life once with a careful emergency room diagnosis that no chart could have done in time. I'm happy to acknowledge my own physician, Dr. Barry Slater, here in the audience today and present at every Maitra lecture, I think. He visited my home regularly to check on my family and me in the days after the shattering sudden loss of my husband in a plane crash. These are AV's ministers of healing, not just administrators of dosages. They are not too good to be true, but they certainly belong to an endangered species that Dr. Verghese is working hard to save. But it is crunch time now. Time to offer up my diagnosis of Dr. Verghese Abraham AV. Is he a lyrical writer, as one reviewer put it, whose sanctity of syntax, deliberate and precise choice of words, and their order in the sentence sets his novel apart? Is he Mahatma Gandhi's idealization, as in, be the change you want to see, a skilled diagnostician and soother of souls? Is he the best friend you could hope to have, prepared to open himself to you and listen to you? Is he Gregory House or Sherlock Holmes in disguise? The reborn Dr. Suman Shah? Is he in Marion Stone, or is it the reverse? Is Abhi a Bengali version of AV, Avi? My teacher has instructed me well. I remember his Occam's razor warning and check off the answers. True, 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 and related. I suppose there should be 7 truths, but I never questioned Lewis Carroll, who once said, "What I tell you 3 times is true." But what's the verdict, Anu? Abraham gently prods me. And in a moment of epiphany that would make even the demanding Dr. Verghese proud, I know the answer. I should not be trying to name a disease. Abraham is the cure. And a la the writer Verghese, I must now use the stethoscope on an addicted and delirious me. I realize that it is I who has the affliction, and it is called Verghesitis. And you all need to be warned. This is a highly contagious disease, especially if you are locked in a room with the 2 of us for a full hour. With apologies, I think, for not bringing you Hugh Lowry and Mia Farrow, I present to you Dr. Abraham Verghese.
Thank you, Anu, for that wonderful introduction. Can you hear me at the back, ladies and gentlemen? It's such an honor to be here. Thank you for those warm words. I can't quite get going because I'm still digesting everything you said. I want to tell you that it's a real honor for me to be here giving this lectureship. If a man is judged by his family and by his friends, then the family that I've met, the friends that I've met tonight, speak of an extraordinary man, and it's really my regret that I never got to meet Sid myself, and I wish I had. What a wonderful tribute to him that so many of his friends have shown up for this. So I'm honored to be in the line of distinguished people who have done this, and I hope to not bring them any shame. I wanted to share with you, to begin with, a story. I love stories. I think stories are instructions for living. I don't mean just true stories, I mean fictional stories too. I love Dorothy Allison's quote. She says, "Fiction is the great lie that tells the truth about how the world lives." And I'm impatient with my colleagues, many of them in medicine, who tell me, "Abraham, I haven't read your book because I don't read fiction. I'm kind of a serious guy, I only read topical issues." And I always want to say I don't, but I want to say to them, "Really, you're a serious person? What about Uncle Tom's Cabin? That book ended slavery in this country." Talk about fiction not being important. I believe in stories, and I want to share a story with you about this person who, in his time, was the most famous physician in the world. I'm a teacher, I'm a pedagogue by nature, so I'll have to ask you, who is this? Don't all speak at once. This is my way of checking that the back row is alive and breathing and participating. Any guesses? So this was Chekhov. This is Anton Chekhov, and when I present this to my students, I always have to say, not to be confused with this Chekhov. But Chekhov, as you all know, was a wonderful writer. He was also a physician. And he died awfully young. He died of tuberculosis. And I've often wondered, how much more would he have added to the canon of his work had he lived another couple of decades? He was extraordinary. He also left us with lots of aphorisms about writing. For example, Chekhov is the one who said, if you introduce a gun in scene 1, you better use it by scene 3. Which I always think is the equivalent of what I tell my students when they want to tell me about a heart murmur. I always say, if you're going to murmur about a murmur, unless you tell me about its pitch duration, what happens with squatting and exercise, do not murmur about the murmur. Chekhov, in the last year of his life, as he was dying, met a wonderful stage actress, Olga. They had a wonderful love affair. She decided to marry him, despite the certain knowledge that he was dying. And a few days before he died, yes indeed, he suddenly got the harebrained notion that he wanted to travel from Russia to the Black Forest of Germany. That was his desire. And being a dying man, everyone moved to make it happen. And so Olga took him to the Baden-Weiler Spa in the Black Forest of Germany. And when he got there, it seemed as though this was a brilliant thing to have done, because he perked up, his color got better, he stopped coughing up blood. In every way, it seemed like a miracle had happened or might happen. But then on the 5th day, he suddenly got very ill and began to cough up massive amounts of blood. And the scene I'm going to recite to you is from Troyat's biography of Chekhov, and the exact passage goes like this. His temples were bathed in sweat, but Chekhov could not stop panting. Dr. Schwarer arrived at 2 o'clock, and Chekhov, in a final reflex of courtesy, sat up, mastered his weak German, and said, "Ich sterbe, I am dying." Dr. Schwarer ordered a camphor injection, but Chekhov's heart did not react. Dr. Schwarer was about to send for an oxygen pillow when Chekhov, lucid to the end, said, "What's the use, doctor? Before it comes, I will be a corpse." And so, Dr. Schwarer ordered a bottle of champagne. When it came, Chekhov took the glass, said to Olga, his wife, "It's been so long since I had champagne." He drained the glass, he lay down, he lay on his left side, he stopped breathing. He had passed from life to death with characteristic simplicity. It was July the 2nd, 1904, 3 o'clock in the morning. A large black-winged moth had come in through the window and was beating madly against the lamp. The sound was terribly distracting. Dr. Schwarer withdrew after a few words of consolation. All at once there was a loud explosion, a joyous explosion. The cork had popped out of the champagne bottle. The moth found its way out of the window and into the sultry night. Silence returned. Olga sat there staring at her husband's face. When dawn came, she said his face was peaceful, smiling, knowing. Writing about it later, she would write, "There were no everyday sounds, there was just peace, joy, and the grandeur of death. Now that passage has always moved me tremendously, partly because it's about one of my heroes, but because in many ways it encapsulates everything I'd like to talk to you about tonight. First of all, I think it encapsulates the fact that any of us involved in illness, any visit to a physician, to a medical facility, there's so much drama involved in that sort of a visit. I remind my students that even if this visit is routine for you, it's not routine for the patient. In Hollywood, they talk about the 3 Ds of drama. Drama equals desire plus danger. And every time we visit a doctor's office, there is a desire to walk away with a nice, good report, and there's always the danger that this will be the first report of something that might shorten our lives, perhaps even end it. From the physician's point of view, I think that this story I find tremendously important. It suggests how easily a physician can catalyze a story and make it have a reasonable ending, or how easily they could destroy that story and make it have a much worse ending than it's destined to have. Small things matter, and this story, to me, encapsulates much of what I'd like to talk to you about tonight. And having set the stage by telling you a story, I want you to, if you wouldn't mind, suspend your disbelief for just a moment and imagine for me, if you would, that an alien comes to our land. This is an alien who has an interest in healthcare. Perhaps he's a physician, an internist like myself, has read a lot about Western medical care on the planet Earth, and decides that he wants to study it. And so the alien comes to visit one of our hospitals. We all know that aliens look like this. The evidence base is strong. And the alien parks himself in a corner of an internal medicine ward, and I pick medicine because it's my field. And one of his worries is that someone will object to this very different looking person standing there in the middle of a ward, but the alien soon recognizes that everybody's too busy looking at digital screens and no one notices that he's there. So he's free to make these observations for weeks at a time without anyone being conscious of his presence. And when the alien has finished a couple of weeks of intense observation and is ready to go back to his planet, these are the conclusions that the alien has made. One, that rounds, which he has read about, are actually removed from the living patient. Secondly, that rounds are actually centered not around the living patient, but around an entity called the eye patient. This is actually a word that I coined. I've become somewhat unpopular in Silicon Valley for saying that the patient in the bed has become almost an icon for the real patient who's in the computer. And just like your iPhone, your iPod, you have an eye patient. And ladies and gentlemen, the eye patient is getting wonderful care all across America. The real patient often wonders, where is everyone? What the hell is going on? Who's in charge? Who's going to explain things to me? But to get back to the extraterrestrial's observations, the extraterrestrial alien believes that the bedside is toxic because most people seem to avoid it. The only exceptions are older doctors who seem unaware of the hazards, but for the most part, no one wants to be around the bedside. And the purpose of medical admission seems to be to render the three-dimensional human into a two-dimensional image. That seems to be the ultimate purpose of admission. And really, the purpose of admission is discharge. Now, I'm being facetious, obviously, but I would ask you to think with me as to how we got to this particular place in medicine, where we have become, in a sense, so obsessed with technology and diagnostics that I joke, but I only half joke, that if you come to one of our hospitals missing a limb, no one will believe you till they get a CAT scan, orthopedic consult, and MRI. And how did we get to this stage where we have become so impersonal in a way? And I wanted to lead you through the recent history of diagnostics. You'll be surprised to learn, my students are surprised to learn, that our ability to make diagnoses, anatomical diagnoses in the body, in the living body, is very, very recent. And we owe it to this gentleman, Leopold Ohnbrugger, living in Vienna. And Ohnbrugger, the story goes, was the son of an innkeeper, And he recalled that his father, when he was a child, would go down into the basement of the inn and tap on the sides of the barrels of wine in order to decide when to reorder. When the meniscus got very low, he would reorder. And Ornberger decided to apply this to the living body. And when he became a physician, that's what he did. He began to tap on his patients, and everything we know about this method that we call percussion, every single thing we know about percussion, Ornberger described in this book, Inventum Novum. Sadly, the book was roundly ignored. No one picked up on it, and Ornberger's work would have just died with him, except for the fact that this physician, Corvisart, who happened to be a very famous physician because he was physician to this gentleman, Corvisart discovered Ornberger's work, popularized it, translated it into French, provided a big introduction, and all of a sudden, the first means of making diagnoses on a live patient arrived. And it's still a very important method of detecting fluid in the lungs, fluid around the heart, and enlarged liver, many other things you can do with it. It was, in a sense, it was the ultrasound of its day. And it was followed very shortly by the discovery of auscultation, the stethoscope. Laennec was Corvisart's student. The story is that he was walking through the streets of Paris, and he saw two children playing with a long stick, and one child was scratching at one end, and the other child was listening at the other end. And this was sufficient for Laennec to think of using that method to develop what he called le cylinder. It was initially a solid cylinder, and then it became renamed the stethoscope. And all of a sudden, the diagnostician had been born. All of a sudden, the physician had arrived, separate from the barber surgeon. See, you have to understand that prior to that time, prior to the arrival of percussion and auscultation, no matter what ailed you, you went to see the barber surgeon. And the barber surgeon cupped you, bled you, purged you. It didn't matter what your complaint was. As I say that, it sounds very much like our emergency room. You arrive, no matter what your complaint is, you get an MRI, a CAT scan. No. The barber surgeon cupped you, bled you, purged you, and yes, if you wanted it, he pulled a tooth and did your hair long at the shorts, long at the sides, short at the back. This was the state of the art, and the arrival of the stethoscope and percussion signaled a departure. The physician carrying a stethoscope was now committing to some kind of anatomical diagnosis, a very different thing than the barber surgeon. You might be interested to know that the barber's pole that you've seen all over the country represents the remnants of the barber surgeon. These represent the bloody bandages that were hung out to dry before they were washed, and this represents the receptacle in which the blood was collected. So the barber surgeon was an important person who got phased out with the development of these diagnostic methodologies, which leads us to the heyday of clinical bedside diagnosis, which in many ways is captured by this very, very famous painting. So both on this side of the Atlantic and in England and all over the world, really, because of the refinement of these skills, there were very skilled diagnosticians capable of making all kinds of conclusions, later confirmed by autopsy, by examining the patient. And I wanted to focus on this painting because it is sort of interesting and important. This is probably the most famous, iconic medical painting ever. It's called The Doctor by Luke Fields. And you probably have seen this in some form or other in many different places. Luke Fields was, let me go back here, sorry. Luke Fields was a very well-known painter, and he was commissioned by Tate of the Tate Gallery to paint a painting of social importance. And he chose this topic, The Doctor, because his son Philip, aged 9, died on Christmas Eve. And he wanted to pay tribute to the doctor who held vigil for 3 days before the death of Philip. And so he decided to paint the scene. And just to take you quickly through this, as you can see, the pictorial space is in the center that captures us is that of a child lying on some dining room chairs. So clearly this is a child who probably sleeps in the back on a straw pallet in what is a fisherman's cottage. The pictorial space is occupied by the child, and there's something about the position of the hand that suggests the child is mortally ill. On one side, the parents waiting anxiously, and on the other side, the physician. And it's interesting, though, that despite this being the era of the stethoscope, the ophthalmoscope, the blood pressure cuff, Fields chose to depict this painting, this physician, without any of those instruments, only with his vigilance, only with his paying extraordinary attention to the child. This painting captured the public's imagination. It was put on postage stamps. It was used in an infamous campaign by the AMA when Truman first tried to bring in socialized medicine. This painting and was used as a poster in doctors' offices. Many of you of a certain age would have seen this painting in your doctor's office because it was used by the AMA successfully to overcome the socialized medicine threat. And there have been thousands of interpretations about what this painting means. And typically they focus on the doctor. My own sense is this painting has nothing to do with the doctor. This painting is about you and me projecting ourselves into the position of the patient and asking ourselves, what kind of physician would we want attending to us in our time of distress? And I think, to me, that's what the painting is about. It echoes the lines in Matthew, I was ill and you cared for me, I was naked and you clothed me, I was hungry and you fed me. It's almost about the Samaritan aspect of being a physician that is evoked in us by identifying, I think, with the patient. And I've often wondered, what would Fields have done if he were commissioned to paint this in the modern era? Let's say James Tate said to him, paint a painting of social importance in the modern era, and he chose to depict the doctor in our time. What would that have looked like? And this is my take on what it might have looked like. The fact is that rounds, very much like the alien described, do not really take place around the bedside as much as they used to. This is Maxwell, Finland, rounding at Boston City Hospital where I trained. This was taken many years before I trained, but Maxwell, Finland was very much alive when I got there. He was in his 80s. Max is a giant of infectious disease. He lived in the hospital. He jogged in its corridors. He was mugged there 3 times. He was very upset when his secretary of 42 years married one of his fellows. But we all felt that, Max, you had all those decades to propose, so. But that is what rounds look like, and the people around the bed are actually some of the luminaries of infectious disease. This is what rounds looks like these days. And one could ask, does it matter? Maybe this is the way technology and medicine need to evolve. And I'd like to share with you 2 anecdotes which have helped me feel that it does matter. The first anecdote I'd like to share with you has to do with a friend of mine who had a breast cancer. This is when I was in Texas. Had her lumpectomy with her local surgeon and physician, and then spent a lot of time researching with many of her friends like me the best place in the world to go for her subsequent cancer care. And she found the place, went there, got extraordinary care. I thought she was quite pleased with it, and which is why I was surprised some months later to realize that she was no longer getting her care there. She had come back to her local physician and was getting her care there. And I pressed her as to why this was, and she was reluctant to tell me, and she finally said to me, she said, Abraham, it was a great facility, very well coordinated care, valet parking, concierge service, all the appointments really pieced together so that you didn't waste your time. But, she said, they didn't examine my breasts, or didn't examine them very well. Now, you and I could argue, they didn't need to examine her breasts. They had her breasts figured out at the molecular level. There was nothing the human hand was going to detect that could improve on what they already knew about her. But the point is, to her, it mattered. To her, it mattered enough that she chose to get her care elsewhere. And to her, it spoke of an inattentiveness in the system. And she preferred to go back to her local oncologist, who every single time she went to see him, did a thorough breast exam, both sides, including the axillary tail, including making her shrug and digging deep into her supraclavicular area. And there was something about that that was important to her. And it stuck with me, because it made no scientific sense, but it made great sense to a very intelligent patient. The second anecdote I want to share with you has to do with a time in Texas when I took care of patients with chronic fatigue. I developed a reputation of being interested in patients with chronic fatigue. This is not a reputation you would wish on your worst enemy. I say that because these are difficult patients. They have been rejected often by society. Witness our laughter when I said chronic fatigue. They've been disbelieved by their families. They have been disappointed by their medical experiences. And I learned with my first patient that I could not do justice to this patient in a 45-minute new patient visit. I could not listen to the whole story, look at all the records, and examine them, and make recommendations in 45 minutes. It was just impossible. And so I hit on the method where I let them have the first visit to tell me their story, and I never interrupted them. We are told that the average American physician interrupts their patient in 14 seconds. And if I ever get to heaven, it'll be because I held my peace for 45 minutes and I let them tell me their story. I then scheduled the physical exam for a second visit 2 weeks hence, and when they came, I did a thorough physical. I like to think I do a thorough physical anyway, but because I had all kinds of time, I did a very thorough physical. And I remember my first patient in the series, a very voluble patient who kept giving me more history, even though we had agreed that this was the physical exam, this was not the history. This very voluble patient kept talking, but as I began my ritual of examining, and I have a ritual, we all have our own rituals. I begin with the fingernails, and then I stroke the palm looking for something called Dupuytren's contracture. Then I slide my hand to the pulse, and then I slide to the elbow, and now I'm in my ritual. As I got into my ritual, this voluble patient began to quiet down. And I remember having a very eerie sense that something was happening, something odd was happening, that the patient and I had slipped back into a ritual of sorts, a ritual in which I had a role and the patient had a role. And when I was done, the patient said to me with some awe, "I have never been examined like this before." Now, if that were true, it's a real condemnation of our healthcare system, because I did a standard exam that we're all supposed to be doing. And then when I made the recommendations to the patient, the standard things that the patient probably heard elsewhere, this is not in your head, this is real. The good news, it's not cancer, it's not tuberculosis. The bad news is we don't know exactly what causes this, but here's what you should do, here's what we should do. I always felt that if my patients accepted the recommendation and gave up on the quest for the magic doctor, the magic treatment, the magic lab test, and instead began on a course of wellness, I always felt it was because I had earned the right to tell them this by virtue of the exam. Now, when I got to Stanford, the great thing about Stanford is you can walk across campus and be talking to world-class anthropologists, world-class sociologists. I went to my colleagues at anthropology and I presented this story to them that I just shared with you. And they said right away, "Abraham, you're describing a ritual. We're very familiar with rituals. Rituals are all about transformation. We engage in rituals, as aliens know and as you know, we engage in rituals to signal a passage. We engage in rituals to signal the crossing of a threshold. We have bar mitzvahs, we have baptisms. We marry with great pomp and ceremony and great expense to signal our transition from a life of misery, solitude, and loneliness to one of eternal bliss." I don't know why you're laughing, because that was the intention, was it not? Well, I would submit to you that the ritual of one individual coming to another and telling them things that they would not tell their rabbi or preacher or spouse, and then incredibly disrobing and allowing touch, which in any other context would be assault. I would submit to you that this is a ritual that's exceedingly important. And it strikes me that patients from all kinds of cultures have different beliefs about medicine and disease, but they have an expectation that when they come to a Western physician who makes them disrobe and puts them in this paper gown, that they'll do something more sophisticated than stick the stethoscope on top of the gown, listen for 2 seconds and move on. There is an expectation of a ritual, and I think that losing that ritual is of consequence. I want to share with you something that I've been reading recently that's quite impressed me. This is work by an ecologist, not a physician, but he makes the distinction between what he calls slow knowledge and fast knowledge, and I think this is really what I've been seeking, is this kind of language to describe a tension between two styles of medicine. And mind you, I'm not a Luddite. I completely embrace technology. I saw a very complex patient today, and I was just thinking that within 1 hour we arrived at a very beautiful diagnosis, elegantly demonstrating exactly where things were in a way that wasn't possible just a decade ago. So I embrace technology, and yet this is a distinction that I want to share with you as I wind this down. Snow knowledge is about resilience, harmony, preservation of long-standing patterns that give our lives aesthetic, spiritual, and social meaning. Fast knowledge is the following. Fast knowledge says if it can't be measured, it isn't knowledge. More knowledge is better, and there's no distinction between information and knowledge. New will always be better than the old. Mistakes and blunders can be solved by more knowledge, and the generation of knowledge can be separated from the application. Whereas slow knowledge rests on these beliefs, that wisdom, not cleverness, is the goal of learning, that the velocity of knowledge is inversely proportional to the acquisition of wisdom, that careless application of knowledge can destroy the conditions that permit knowledge to flourish, and rising volume of knowledge cannot compensate for increasing errors caused by stupidity generated in part by inappropriate knowledge. And finally, and when have you ever heard someone talk about character in the context of care delivery? The good character of knowledge creators is relevant to the truth they intend to advance. I want to close by sharing you two things. One is a quote from one of my heroes, William Osler. William Osler is the granddaddy of American medicine. Osler did 200 autopsies in 1 calendar year, and that's what he had to do to make the kind of correlations between what was happening on the body on the outside with what was happening on the inside. And he was a superb physician. We have about 7 things on the body named for him: Osler's nodes, Osler's maneuver, Osler's disease, and so on. And I often think if Osler had our instant technology, the ability to see things so clearly within seconds, Osler would have been 100 times better than any of us are, 100 times better than he was. But this is what Osler had to say. Remember, however, that every patient upon whom you wait will examine you critically and form an estimate of you by the way in which you conduct yourself at the bedside. Skill and nicety in manipulation, whether in the simple act of feeling the pulse or in the performance of a minor operation, will do more towards establishing confidence in you than a string of diplomas or the reputation of extensive hospital experience. I want to read you something in closing that I wrote some years ago, looking back on a very difficult period in my life. I, like many physicians my age, lived through an extraordinary era of HIV, where for years we had no treatment, and we presided over young men, mostly my own age, who were dying. But they weren't just dying, they were dying after 2 or 3 years of having been my patients and having become sort of more than patients, my friends, people that I learned a tremendous amount from. And it was hard for me to go back and think about those days, but recently, or not that recently, I wrote about this, and I wanted to share it with you because I hope it provides the fitting conclusion to this wonderful opportunity to talk to you. So this is taken from a journal called the Journal of Health Affairs, from a section called Narrative Medicine, and here goes. Can you still hear me at the back? You still breathing, alive? Okay, good. There is an indelible scene that comes back to me often and without invitation. But in recalling it as I write this, I'm no longer distressed. It has taken all these years for me to find reassurance in the memory. It harks back to the time when I made regular visits to the bedside, to the sick beds of patients dying with AIDS in the era before modern therapy. I remember my reluctance, my sense of failure, a sense that enveloped me when I went by the room on rounds or when I paid a home visit. I never knew quite what to do, what to say. And out of that awkwardness with the dying, out of that embarrassment, I'd fall back into the only role I knew to play at the bedside. I would feel the pulse. I would gently pull down the eyelid to see the color of the mucous membrane. Then I would examine the tongue. Then I would sound out the hollow chest with the time-honored technique of percussion. I would listen to the lungs with my stethoscope, then feel the abdomen. My ritual. I recall so many pairs of eyes of so many people, all of them now long dead, but their names still vivid, fresh on my tongue. Huge haunted eyes in hollowed out sockets staring up at me as I perform my exam. And when I was finished, I'd take my leave, and the next day I would do it again. I recall one patient who was at that point no more than a skeleton encased in shrinking flesh, unable to speak, his mouth crusted with candida that was resistant to the usual medications. When he saw me on what turned out to be his last hours on earth, his hands moved as if in slow motion, and as I wondered what he was up to, his stick fingers made their way up to his pajama shirt, fumbling with his buttons. I realized that he was wanting to expose his wicker basket chest to me. It was an offering, an invitation, one that I did not decline. I percussed, I palpated, I listened with my stethoscope. I think he surely must have known by then that this was a vital ritual for me, just as it seemed necessary for him. Neither of us could skip this ritual, which had nothing to do with detecting rales in his lungs or finding the gallop rhythm of heart failure. No, this ritual was about the one message that physicians have needed to convey to their patients, although God knows of late, in our hubris, we seem to have forgotten. We seem to have drifted away, as if with the explosion of knowledge, the whole human genome mapped out at our feet, we are lulled into forgetting that the ritual is cathartic, forgetting that the ritual has a meaning and a singular message to convey to the patient. And the message, which I didn't fully understand then, even as I delivered it, and which I understand better now, is this: I will always, always, always be there. I will see you through this. I will never abandon you. I will be with you through the end. Thank you very much. I'm never sure if I can get through that letter. It's a tough one to read. We have time for questions. I'm very happy to hear your comments or your questions. Do wait for a microphone. There are folks with microphones, I'm told. Yes, so sir, back there, and they'll bring a microphone to you. Where are our microphones? Oh. Thank you for your patience with the microphone. I wouldn't be able to hear you otherwise, and neither would the audience.
Thank you very much, Dr. Verghese, for that really inspiring and insightful talk. My question is, in this era and age and time of increasing heartlessness in our country, so where there is barely time for reasoned practice of caring medicine, where is there time for ritual, and what is the medical community and what can people at large do to make sure that we put this train back on track? Your goal of practicing the ritual totally resonates with me, but it also sounds a little bit audacious in today's America. So what are you doing? What are the medical community doing? What is AMA doing? And what can we all do to preserve and protect the ritual and your beautiful way of dealing with healing rather than just trying to buy healthcare or buy insurance? Thank you.
So I've had a little hard time hearing you over here, but I think you were asking about what am I doing to disseminate the ritual and where's the time for it?
To preserve the ritual. I mean, can we do that? Your goal seems to be rather audacious. So how do you actually do what you want to do, preserving the ritual?
Okay, so I think, I've had this interest in bedside medicine for many, many years. It's been sort of my monomania. But the lovely thing about coming to Stanford is I finally have a bully pulpit that is a good one. And it's a great place to speak from, and I've certainly been taking lots of advantage of that. It strikes a chord with many people, there's no doubt about that. And I think that one of the fallacies that I think exists is that younger doctors don't want to learn this. That's far from the truth. I think that my medical students get very excited learning this stuff. And if you ask them, for most of them, that's why they came to medicine. The sense that they were going to get this specialized, knowledge and ability to deal with people, to read the body as text, and to be able to sort of make the skilled conclusions that people have been making for 100 years. So there's a lot of interest and excitement in learning this, and I think we have to show that it has value. We have to show that it has value, and I think, frankly, one of my colleagues, Alan Garber, a medical economist and physician, actually he's no longer my colleague, he's now provost at Harvard, but Alan Garber wrote in a great editorial, he talked about our healthcare being the menu without prices. You can order filet mignon every night, and I never stop to think about what something costs in the hospital, nor do my house staff, because we're just sort of used to this notion someone else is paying. I think if that changes, it would be easy to show that there would be value in ordering things more judiciously, rather than ordering things willy-nilly the way we do right now. There's an anecdote that I've talked about before about a woman we saw in our emergency room who came in with a blood pressure of 250 over 180, collapsed within a few minutes, was stabilized, intubated, taken to the CAT scan suite next door to demonstrate if she had blood clots to the lung. That was a suspicion. She didn't have blood clots to the lung. She had bilateral, palpable breast masses. They were visible and palpable, and they were widely disseminated all over her body. And she had had about 6 encounters with healthcare workers in the 2 years preceding this. And you could look through her chart and see all kinds of tests ordered, but had one human being, done the trouble of a good exam, it might or might not have changed her fate. But my point is that there are huge inefficiencies by our not doing this sort of thing. And I think the challenge for us at Stanford, which is what we're working on, is to demonstrate the efficiency of doing this. A very common criticism I hear is, oh, well, it takes too much time to do that. And I can't tell you how much time it saves to spend an extra 5 minutes and listen and find out that what it's really about is not what it's about. There's a whole different story being told, and you can spare the patient radiation. I think the American public is just coming around to the notion that many CAT scans are not a good thing, and that you should resist this idea of getting everything scanned and tested. And so, that's the challenge. I think we're in a great place to make the case. And the message I shared with you tonight, I think has been getting out there, and it's certainly striking a chord. So I hope that answers your question. Who has the mic? Up there on the left.
I understand what you're saying, and it seems to me it's a monumental problem to create the ambience that you're talking about, in the sense that when you, for example, in Santa Cruz, anyone here who goes to the Santa Cruz Medical Clinic, which is a PAMF
A little louder, I'm sorry. Hold that a little closer.
Okay, yeah. Sorry. Anyone who goes to the PAMF clinic here in town, the appointments are set up based on what you are making an appointment for. You're given 15 minutes, you're given 20 minutes. The tests are all there, but it seems to me there's not the time for most doctors for any kind of discussions. I mean, they're very brief, they're very focused. They don't go beyond the reason that you've come in for. And I don't know how you change that operating philosophy that seems so prevalent now. I mean, I think it's great that Stanford can do that, but I'm thinking about all the other medical practitioners and insurance companies.
Yeah, I think that's a very fair observation. I think that our medical practice is entirely shaped by reimbursement. I mean, we are, everything we do is shaped by reimbursement. I mean, I tell my students, you've seen freestanding birthing centers, freestanding surgery centers, freestanding cancer centers, freestanding heart centers. You ever seen a freestanding geriatric center? With valet parking and concierge? There's no money in it. There's no money in it. 80% of the revenues of a big tertiary care hospital come from the cancer care center. And so long as our reimbursement sort of shapes our practice, we will have this sort of skewed system where the primary care people are forced to make short visits, frequent turnover in order to cover the overhead. The fact is, in psychiatry, for example, a 15-minute medication visit makes you more money than a 45-minute psychotherapy encounter. So who in their right mind continues to do psychotherapy and lose money? You know, and so we have a system. We have a system where, you know, you are paid to do things to people, not for people. So if you can stick something in, poke something in, prod, you know, do something to a person, you get reimbursed very well. If you try and do something for a person, such as in the case of my aged parents, listen to them for a good half hour and then take the time to explain what's going on, you will lose money. There's no money in that. And so, just because reimbursement has skewed the way we practice, I don't think I or any of us should hold out that that is the way it is. We try and tell our students who are the best and brightest that maybe they will get to change this and bring it back to where it should be. There isn't much doubt about where it should be. How do we get there is a big question. Who's got the microphone? Yes.
My husband was dying of cancer at Stanford Hospital about 20 years ago. And of course, as you know, it's a teaching hospital, and his own physician came around, escorted by about 9 or 10 interns. And he said, my husband said, please don't just talk to me, you the physician. I want to hear from the interns. And he said, unless I can know your name and have you touch me every time you come in here, I refuse medication and treatment. Tell me, 20 years later, does that kind of patient rebellion, has it done any good? Did it leave its mark?
Yeah, I wish I could say that it doesn't happen. I think, you know, one of the drawbacks of tertiary care is that it is so complex. I mean, some of the patients I'm calling on have had their second liver transplant and have a bizarre fungal infection of the brain from immunotherapy that I've never heard of before, and I'm an infectious disease specialist. You can imagine the number of consultants that come in. It's a danger, I think, at every tertiary care hospital. I heard a very well-known president of one of our organizations talk about his illness. He's a young man, he's younger than me, and he had a hospitalization for a malignancy. And he said, he paged the intern and said, do you know anything about patient so-and-so? Can you tell me? And the intern said, you know, well, all I know is that he's doing well and his condition's stable and he's set to go home tomorrow. Can I ask who you are? He says, well, I'm the patient and I haven't seen you. And I have no idea, you know, what's going on. And so I think that there are, you know, I would be lying to you if I said, you know, things had changed remarkably. I think we're capable of making bigger mistakes on a much bigger scale 20 years later. And it strikes me often when I see a patient who 40 other consultants have seen. I mean, 40 other teams literally have been in and out of the room. And I have a difficult last name. It's not the easiest name to remember. And patients will sometimes say, I wanted to run this by that doctor. I don't remember his name, but he's the one who examined me so well. And mind you, when I'm seeing a hospitalized patient, I don't examine them that well. I examine quickly and methodically, but it's not a half-an-hour exam. It's a 5-minute, but it is an exam. And it stays with patients, and I think that's the message we're trying to convey. As your husband deduced, that if you don't touch, you're not engaged. When I was a younger intern, I had an ICU attending, and when you're an intern, the ICU, intensive care, is an exciting place, you know. And the older you get, you realize how boring a place it is. Because the moment patients wake up and can talk and speak, they're ejected from there. So it's only exciting if you want to support systems and play with numbers, you know. And I had an attending, I never forget, he would make us present by putting our hand on the patient and first saying something about the patient's name, age, and a little bit about who they were, before telling us about the creatinine and the white count and all that stuff. And I thought that was a very powerful lesson. So I applaud your husband for having said that. I think it's important.
You described very beautifully how a dying patient directed your hand to his chest so that you could engage with him in this ritual. Do you have anything more to say about how patients can encourage doctors to realize their full humane potential?
Yeah, I think, you know, I think that many of my colleagues in primary care have abandoned primary care to become concierge doctors. And if you're asking me as a consumer what you should do, I find myself thinking that's probably what you should do to get your doctor's attention and time. Because the fact is, in primary care, you have to see about 25 to 30 patients to meet your overhead. And you can't do justice to them. You are frustrated and you're wrapped up with insurance companies and billing. So many physicians I know have become concierge doctors, where they have a panel of 300 people, charge them a capitation fee of some sort. It's the kind of medicine that we all thought we wanted to practice. And yet I think it also jars some of us because we don't want to exclude anybody. But I think that, you know, the fact is, as healthcare gets more and more expensive, I don't know what it is now, 16% of the GDP, and as more and more people recognize that they need more and more complex care, and as we get fewer and fewer primary care physicians, we're sort of heading for a perfect storm. I don't quite know what will have to happen. I think we'll have to cut police and fire services and not repair the highways, and then people will realize, you know what, we're spending too much money on healthcare. We've got to do something, but it hasn't happened yet, so I'll have to wait for a microphone. There's a hand up here. Last one. Okay. This is the last question. No pressure.
Well, I'm privileged to be a news doctor, privileged because she's become such a good friend and I get an opportunity to attend these programs every year. And I'm in family practice, not in concierge medicine, and I just thought I'd share with you the last patient I saw. I had to leave early to come here tonight, and she's a patient I've seen for 40 years. I started seeing her when she was 60 years old, and she's 100 now. I've seen her 40 times, and she comes in on her birthday. And she's been in very good health. As a 100-year-old woman, she now, you know, she doesn't see very well or hear very well, or her memory, her short-term memory is not good, but her long-term memory, I asked her medications, and she told me that she's taking hydrochlorothiazide 12.5 milligrams once a day. She's taking lisinopril 10 milligrams once a day, so her memory is still pretty sharp. And I did my exam, and then as I was doing my physical exam, she's always been in very good health, and as I say, she only comes in for the physicals. I did feel a very distinct breast mass in her left breast that I hadn't felt last year, and I'm sure it was breast cancer. And her daughter was there, and then I listened to her heart, examined her abdomen, and did the rest of the exam. And she said, "Well, how am I, doctor?" And I said, "Gladys, you're fine." And it was a decision I made, an unheroic decision, but one that I thought about while I was doing the rest of the exam, wondering what the benefit of informing her of that would be and what it would entail doing the diagnostic and treatment part of it. So I just thought I would share that with you as being the other part of medicine. Sometimes it's more ambivalent, and but her last words to me were, "Thank you, I'll see you again next year." And we hugged her, and that was
wonderful. What a nice way to close. Let me thank the folks here at the university. I had a wonderful visit with the students from the science writing program and creative writing. I've just enjoyed my first visit to this beautiful campus. I hope it'll be many more. Thank you for being such a wonderful audience, and enjoy the rest of the evening.